So, as Glenn says, I'm afraid you've got me instead of Dr. Keith Ridge. I do send Keith personal apologies. He's very, very supportive of this work and recognises the importance of GS1 in transformation of the NHS, which is what is needed. He's been very closely involved in some of the Carter work, and I know that he did specifically want to be here, which is why he said 6 months ago he would love to do it. But unfortunately, as is the breaks working with the department, we occasionally have engagements that we can't get out of, as you can probably imagine, and Keith has been summoned to one of those today. So unfortunately, you get me. The downside of that is that I will give you a very dry presentation, whereas I'm sure if you had had Keith, he would have been a lot more visionary, as is his responsibility. So I'm just going to talk very dryly around the Falsified Medicines Directive and the recent Delegated Act and what that has in store for us. So the Falsified Medicines Directive was a directive from the EU way back in 2011, and its fundamental principle is all around reducing falsified medicines in the legitimate supply chain. The idea being that we should be able to have a certain secure supply all the way through from any ingredients that go into medicines through manufacturers, wholesalers, and supply to the end patient. What does it mean by falsified? So it's anything with connected with that medicine, so its documentation, its ingredients, its records, that anything to do with it may be falsified. It's not just actually about the active ingredients. So there have been instances of falsified medicines when actually the product is perfectly okay, but there are inaccuracies, falsified records about it. That would be a falsified medicine, which we would not want in the supply chain. So just to try and describe what the Falsified Medicine Directive does, it's all-encompassing. It covers everybody in the supply chain, but it was made up of different components. So it started, and way back in 2013, I think it was, we had to shore up any active ingredient or even excipients. So any suppliers of those have to be registered with the competent authority, which in our case is the MHRA, in order to be able to supply those things to manufacturers. So that part's already implemented. Last year, in July, we had to do the internet sales, which was around anybody who supplies medicines to the public over the internet had to have a logo, and if you click on that logo, it should take you through to show that they are a registered supplier. And what we're now talking about, and what the recent Delegated Act was, the safety features, which have to be on all medicinal products. So the idea of the safety feature is that you can use it to verify that the medicine is authentic, and that you can also identify that the product hasn't been tampered with. The safety feature is made up, therefore, of two components. It's the unique identifier, which is very specific to that pack. So it wouldn't just tell you that it was a blue duck, it would tell you exactly which blue duck it was, so that you could identify it specifically. But it's also around having Tamper evident packaging as well. It applies to all prescription-only medicines unless they've been exempted, and there's a handful of exemptions, so for example, gases. It doesn't apply to P medicines or GSL medicines unless there's already been an issue of falsified, so it has currently got to only apply to one, which is omeprazole. So the composition of the unique identifier, I'm not a techie, so I'm sure those of you in the room, this would be of importance to you, but skates over my head, I'm afraid. So it has to be an alphanumerical number. It's made up of the product code, but then also the unique part of the code. If the member state so requires, it has to include a reimbursement number. It also has to include the batch number and the expiry date. It has to be a two-dimensional data matrix barcode, but they also have to put the information in a human-readable format on the product. And they're not allowed to put any other code on the pack. So the idea being that if somebody goes to use the code, there is only one code, and there will be no misunderstanding where they're trying to use another code which isn't the right one. The Tamper Evidence, the directive doesn't actually say very much about this other than that they're required to include it. There are already European standards around this, and it'll be up to manufacturers to choose which one they want to use, if indeed. And obviously some of these Tamper Evidence mechanisms are very sophisticated these days, and it'll be for manufacturers to choose how sophisticated they want to be. So what is the general idea? That the supply chain can check using the unique identifier at any point whether it has an authentic product. So the unique identifier will be uploaded into a central repository, and at any point in the supply chain, if you have concerns, you can verify that unique identifier against that repository, and obviously you can also check the Tamper Evidence sealing. More specifically, at the point of supply to a patient, so particularly pharmacies, when they supply the product to a patient, they will have to decommission that unique identifier from the central repository. For those of you who are still with me, you will have quickly identified the flaw in this, that if the repository comes back and says, your code isn't valid, it doesn't actually really tell you anything. Because is it your product that was falsified, or has somebody else had the falsified product with a unique number on it and already decommissioned it out of the repository? So all you know is there's a problem, but you don't necessarily know whether it was your product or somebody else has already stolen your unique identifier. But nevertheless, in its wisdom, this is what EU decided would work for us. It does make provision for part packs, so it recognises that you may not supply a whole pack to a patient, so you decommission the pack at the first point when you split it. It recognises that there may be technical problems that you can't decommission at the time, so it sort of says, well, as long as you know that this isn't falsified, you can supply it to the patient and decommission it later. But it also recognises that there are certain times when you might want to check it back in, but you have a 10-day limit, so once it's been decommissioned from the central repository, you can only check it back in 10 days, and it has to be by somebody within the same legal entity who decommissioned it in the first place. So quite strict criteria about putting something back onto the market. So this is just to try and show that the manufacturer has to produce the unique identifier, that has to go into a repository. Wholesalers can use that to verify at any point if they want. More importantly, they have to verify on a risk-based account, so anything that's come from somebody who is not the manufacturer or the manufacturer's authorised agent, or if it's a return, it will have to verify that the unique identifier of products that it has is legitimate. And then also anybody who supplies to the public, they will have to verify and decommission when they actually hand it over. So establishing the repository, I will whiz over this because Rick will talk a little bit about this later. So manufacturers are tasked with this. It's their responsibility to establish this repository. Others in the supply chain can contribute, they have to be consulted on, but ultimately it will be for the manufacturers to do this. They have to form a non-legal, not-for-profit legal entity to actually manage this repository. So it's a massive undertaking for our pharmaceutical industry. They've got to talk to each other and they've got to pay some money to make this happen. There will be a central European hub, and there will also be national hubs, or there will be hubs that go across member states. So if you think about medicines that flow around Europe, you could have the code going into the European hub and coming down into the national hub, or going into the national hub and going up into the European hub as medicines flow around Europe. Obviously, there are significant data concerns. The data will be of huge commercial interest, so the repository's got to be extremely robust, resilient, and access controlled. National competent authorities will be allowed to have access, so we'll be allowed to have access to supervise it, to ensure that it's functioning as it should be, but we can also use it for reimbursement. So particularly other member states, so France and Spain and Germany, they wanted to use this to be able to ensure that they were only paying for what patients had had. We may get to that, but we don't have a particular business case used for that at the moment. But obviously for pharmacovigilance, pharmacoepidemiology, MHRA are very interested in seeing how they could pursue the data within the repository for those reasons. The Delegated Act does give us some flexibilities. It does allow us to say whether we want to have a reimbursement number within the code, and it also says that you can allow the code to be put on other products that the Delegated Act doesn't require it to have on it. It also allows us to allow manufacturers to put additional information in the code if they want to. There are other flexibilities, more to do with the operational, which is the decommissioning. So in particular, and this is a huge flexibility, which we will want to think very, very carefully around how we use it. So the fundamental principle is that those who supply the medicine to the patient has to decommission it from the hub to say this unique identifier, this product is no longer available because I've supplied it to a patient. But it does say that we could allow wholesalers to do this on behalf of some people who supply to the public. Unfortunately, we can't allow that flexibility to healthcare institutions, of which hospitals are within that definition, or pharmacies. So you may say, well, who else supplies medicines to the public? But actually, quite a lot of other people do. So even if we think about ships and aeroplanes and prisons, we have clinics that are led by nurses. Particularly in the UK, we opt to use these flexibilities a lot more than other member states. So this particular flexibility potentially will be very useful to us. But as I say, unfortunately, we cannot give that flexibility to hospitals and pharmacies. So they will have to decommission products themselves. It does allow flexibility where a hospital also has a wholesaler. It can do the decommission. That wholesaler can do the decommissioning on behalf of the hospital if they are part of the same legal entity. So there's also provision for decommissioning things like samples and things which are going to be need to be destroyed. It ensures that those things are decommissioned. And it also has the flexibility of allowing healthcare institutions, of which hospitals are one, that you could actually decommission at any point that you want to. So you don't necessarily have to decommission at the point of supply to patients, which community pharmacies are going to have to do. You could actually decommission at any point through your legal entity. So quite important flexibilities for us around how we might implement this and make it operational. So I hope what you will have picked up is the implementation challenge that this FMD presents to us, just the pure scale and complexity of it. I've been sort of involved going backwards and forwards to Europe around the casting of this Delegated Act, and it was very clear in Europe. They had a very simple model in their head, which was manufacturer, wholesaler, pharmacy. They had absolutely no understanding of the complexities and how products, go from manufacturer to wholesaler to wholesaler to wholesaler, and eventually end up maybe at a hospital, maybe at a prison, maybe at a ship, maybe at in a doctor's black bag. They just had no understanding of that concept, and they just thought it was very simple. So we've worked very hard, which is how some of those flexibilities come around. But nevertheless, even with those flexibilities, we are still left with a very big challenge. Even if we just think in primary care, we have over 1 billion prescriptions dispensed a year. That's more than 1 billion packs, because each prescription could have more than one pack. Every single one of those packs has to be decommissioned through that repository. While it isn't an IT project is a very important aspect of it. We've got the procurement of the central repository, which Rick will talk a little bit about. We've got to have interoperability between anybody who supplies medicine so that they can interact with that repository, and they're going to have connectivity that's operational at any point that they may need to decommission a product. We've got how the decommissioning is actually going to affect our interaction with patients. The last thing we want is another piece of red tape that we've got to do before we actually can get something to a patient, or getting in the way of our interaction with a patient. And then we've got the 10-day rule to think about, and to ensure that we're not wasting medicines or losing more value for money because we're having to disregard them because they've been decommissioned but haven't actually got to patients and we can't use them. There are a few opportunities, the flexibilities which I've talked about, and then the Commission is quite clear that we can use something called aggregated codes. So if you think about a wholesaler where they've got a whole pallet of something, they could just have one code which would verify the whole packs on that pallet. Or alternatively, in community pharmacy, if you had packaged up Mrs. Brown's 10 tablets, you could have one code on the outside of her pack, which when you scan that, actually decommissions all of those 10 packs within her pack. So we need to think to make sure that we're using those to make this as efficient and as smooth as possible. However, hopefully, if you're still with me, you will have also spotted that the potential of the data that this will create for us is absolutely enormous. for the first time, we will potentially have some record of every single supply of medicines to patients that will have easily have been captured through this scan that we've got to do anyway. So it would be scandalous if we didn't take the opportunity to use that more widely, both for direct patient benefit, so exactly what GS1 is all around right care, right patient, right time. So when we're scanning, we can ensure that we've given this to the right patient and it's the right product. But also other things, patient recall, monitoring their regimes, but more widely, so the system benefits just generally around outcomes, the opportunity to minimise fraud, to get more value for money, commissioning, the opportunities this provides for CCGs who are grappling in a new commissioning world, research, targeting interventions, the potential is huge, but also the data base is going to be huge, the interactions are going to be huge. To actually harness that data is going to be, a huge logistical challenge for us, and we need to think carefully about how we do that. And in order to think about that, we've set up an implementation board, which I'll talk about in a minute. So just specifically then for hospitals, so what are the implications for GS1? So all products will have to have a barcode. It doesn't necessarily have to be GS1, but it does have to be in an ISO standard, so it would make sense, but you will want to consider putting pressure through to ensure that it's GS1 and it fits with what you're looking for. How will the product description that I talked about earlier, how will that link with things like DM&D? Then we've got the implementation of the decommissioning. So not all medicines particularly go through hospital pharmacies. So if the hospital said, well, actually, we're just going to scan everything that comes through the door straight away so that we know it's been decommissioned, you don't get the wider benefits, but also there will be the odd medicine that doesn't even come through the hospital pharmacy. So you'll need to ensure that they're picked up. Making sure that if you are scanning for wider benefits, you're not having to scan twice. Let's just do it all in one scan and not let that scan get in the way of our interaction with patients. Are there concerns around what this 10-day limitation means if we've got things flowing backwards and forwards between the hospital pharmacy and the wards, possibly other hospitals that a hospital may supply, thinking very carefully around where that scan takes place to reduce waste and making sure that once you've supplied something, it's not going to come back and you're not going to want to recheck it back in. And obviously some hospitals have wholesaler dealers licenses. They'll need to think very clearly about which products, making sure that if it's for their wholesaler dealers license, they can't scan it out because that's for the person who supplies to the public. So particularly to help the DH and the MHRA, and particularly around the flexibilities and how we might want to implement them, we have set up an implementation board to support us and to work through this. So if people do have thoughts that they want to contribute, please find people who are on that implementation board. I've put up the names of the 3 hospital reps. I know at least one of them, if not 2 of them, are around over the 2 days here. So please do catch them and talk to them and make sure that your issues are captured, because this is very much a new thing that we are all finding our feet, and we have to find the best way through to make this seamless, but also to ensure that we're not missing a trick and not losing the wider benefits.